Welcome to BFR Radio, a podcast dedicated to all things blood flow restriction training. This podcast is proudly sponsored by the BFR.co, where if you want to buy your own BFR cuffs, access online BFR training programs, or you want more information about this type of training, this is your one place to go. And I'm your host, Dr. Chris Gavilio. I want you to think about something. If you're working with a chronic low back pain population, how often do you see genuine hypertrophy or meaningful strength gains from traditional core stabilization programs? I'm not saying they don't reduce pain or improve function, they absolutely do. But are we actually changing the size or activation capacity of the multifidus or transversus abdominis in a clinically meaningful way? Or are we just improving coordination and motor control? That's the question this episode is looking at today. Hi everyone, and welcome back to this episode of BFR Radio. In our last episode, we looked at blood flow restriction in the shoulder, particularly post-surgical context, and how BFR can selectively enhance muscle mass, strength endurance, and activation even under low mechanical loads. That discussion centered upon upper extremity work, but the underlying question was the same. Can we get meaningful neuromuscular adaptation without the compressive or tensile stress that comes with traditional heavy resistance training? Today, we're taking that same question and applying it to one of the most common and challenging populations we see, individuals with nonspecific chronic low back pain. The study we're looking at today is titled Effect of Blood Flow Restriction Training with Core Stabilization Exercise on Muscle Activity and Muscle Thickness in Subjects with Non-Specific Chronic Low Back Pain, published in the Journal of Back and Musculoskeletal Rehabilitation. Let me start by explaining why this study matters in the context of current low back pain management. Chronic low back pain is defined as pain localized between the costal margins, that is, the lower edge of the rib cage, and the inferior gluteal fold, which corresponds to the bottom crease of the buttocks. And this persists for 12 weeks or more. In roughly 85% of cases, the exact cause is unknown, and these cases fall under the umbrella of non-specific low back pain. More than 90% of low back pain presentations are non-specific, meaning we can't pin down a single structural lesion or pathology. What we do know is that muscular dysfunctions play a central role, particularly imbalances in the transversus abdominis, multifidus, and gluteus maximus. To picture how these work together, think of the transversus abdominis as a built-in corset wrapping around your midsection to brace your core. The multifidus as tiny, heavy-duty laces tying your individual vertebrae together for fine-tuned stability. And the gluteus maximus, the large powerhouse muscle of your backside, as the main anchor driving your movement. When these muscles are weak or poorly coordinated, trunk stability suffers, thoracolumbar fascia tension drops, and the spine loses its ability to maintain load through what's called force closure, which is the extra stability created by muscle contractions compressing the joints. That's the biomechanical backdrop. Core stabilization exercise has strong support for improving pain and disability in people with non-specific chronic low back pain. The goal is to retrain the synchronic activity of the deep stabilizers, the transversus abdominis and multifidus, while also addressing the gluteus maximus, which helps to stabilize the pelvis during trunk rotation and weight bearing. When you lift something, the gluteus maximus co-activates with the contralateral multifidus to create a force couple that supports the spine through the thoracolumbar fascia. If that system is weak or poorly coordinated, you lose spinal stability and increase the risk of pain and injury. Traditional core stabilization programs are effective at reducing pain and improving function, but they're typically performed at low loads and low intensities. That's by design. We don't want to overload an irritable spine. But the trade-off is that low-load work may not provide enough mechanical or metabolic stimulus to drive meaningful hypertrophy or high-threshold motor unit recruitment. That's a problem because most people with chronic low back pain have atrophy of the multifidus and reduce thickness of the transversus abdominis. If we can't restore the muscle mass and strength, we're leaving performance and resilience on the table. That's where blood flow restriction comes in. BFR training allows us to perform low-load exercises while still achieving adaptations typically associated with high-load training. The hypoxic environment and metabolic stress helps to stimulate muscle protein synthesis via the mTOR pathways, which is basically the body's master switch for muscle growth, and the accumulation of metabolites, which triggers afferent feedback that recruits high threshold motor units to maintain force production. What's particularly relevant to this study is the concept of remote or systemic adaptations. Even though the cuffs are applied to the legs, the exercise performed aren't leg or quad dominant. The exact mechanism isn't clear, but it likely involves systemic hormonal responses, increased circulating growth factors, or neural adaptations that cross-transfer to the non-restricted muscles. The study is designed to test whether that remote effect extends to the deep core stabilizers and whether it translates to functional improvements in disability. This randomized study involved 38 individuals with non-specific chronic low back pain. They were randomized into two groups, BFR plus core stabilization exercise and core stabilization exercise alone. Participants had to be between 18 and 45 years old, have a history of lower back pain lasting more than 3 months, with pain localized between the costal margin and the gluteal fold without radiation into the lower extremities, and a disability score of at least 19% or higher on the modified Ostrey Disability Questionnaire, which is a standard survey used to measure how severely lower back pain impacts a person's daily life by scoring their ability to do everyday tasks like lifting, walking, and sleeping, where an overall higher score means greater disability. For the BFR, a 10 centimeter wide pneumatic cuff was used and inflated to 80% of arterial occlusion pressure. The core stabilization exercise program was identical in both groups, with the only difference being the presence or absence of the BFR cuff. The program was progressive over 4 weeks, divided into 3 levels. All exercises were performed with a hold time of 10 seconds per repetition, 3 sets per exercise, and 60 seconds of rest between sets. Let me break down each level. Level 1 in week 1 started with a 5-minute warm-up on a stationary bicycle. Then participants performed abdominal drawing-in exercises. Think of this as a gentle co-contraction of the transversus abdominis without movement of the spine or pelvis. They also did abdominal bracing, which involves simultaneous co-contraction of the transversus abdominis, multifidus, and other trunk exercises. Finally, they performed alternate arm and leg lifts. Level 2 in weeks 2 and 3 progressed to unilateral bridging. Think of it as a single leg glute bridge. Quadruped contralateral arm and leg lifts, quadruped meaning in all 4 positions on your knees and hands, diagonal curl-ups and sit-backs, and prone hip extensions. Level 3 in week 4 introduced bridging on a Swiss ball, diagonal curl-ups with an elastic band, trunk extensions on a Swiss ball, and unilateral bridging with an ankle weight added for resistance. Just a little note is that there was no pictures or link to an appendix in the paper, which I think would have really value added to the applied nature of this paper. All sessions were supervised and performed 3 times per week for 4 consecutive weeks. That's a total of 12 supervised sessions. The BFR group had the cuff inflated during the exercises. I couldn't actually find in the article whether pressure was released in between the rest periods or not, so I can't comment on that. However, you might actually think that because of the long hold time, that's 10 seconds per repetition, is that perhaps that they did decrease the pressure somewhat in between. And if you've never used BFR before, I'd probably employ that strategy anyway. For outcome measures, the primary outcome were muscle activity measured via surface EMG, muscle thickness was measured via ultrasound imaging, and the disability was measured by the modified Ostrey Disability Questionnaire. For muscle activity, the researchers used surface EMG to assess the transversus abdominis, multifidus, and gluteus maximus. In this, the participants performed maximal voluntary isometric contractions for 5 seconds. And this tells us how much of the muscle's full activation capacity is being recruited during the task. For muscle thickness, they used ultrasound imaging with measurements taken at rest and during contraction. Finally, disability was measured using the Modified Austrian Disability Questionnaire. As I briefly mentioned before, this is a widely used self-report tool that assesses how low back pain affects 10 domains of daily living, including pain intensity, personal care, lifting, walking, sitting, standing, sleeping, social life, traveling, and employment or home making. Each domain is scored from 0 to 5, with higher scores indicating greater disability. The total score is expressed as a percentage, with 0% indicating no disability and 100% indicating maximum disability. All outcome measures were assessed at baseline and again after the 4-week intervention. Turning our attention to the results, let's start with muscle activity, because this is where we see some of the most pronounced differences between the two groups. For the transversus abdominis, the BFR plus core stabilization group increased from 29 to 56% of maximum voluntary contraction over the 4 weeks. That's a statistically significant 27-point gain. The core-only group went from 30 to 39%, which is a non-significant 9-point increase. Clinically, this means the BFR group recruited far more motor units to generate force for spinal stability. For the Multifidus, the BFR group saw a significant 25-point increase, improving from 30% to 55%, whereas the core-only group improved significantly, but was only a 12-point gain. While both improved, the BFR group's gain was significantly larger, resulting in a much more neurologically active muscle for stabilizing the spine under load. Finally, for the Gluteus Maximus, the BFR group improved a massive, significant 32 points, from 44 to 76%. The non-BFR core-only group saw a non-significant 5% increase. In the clinic, this translates to significant better hip extensor activation during functional tasks like lifting and walking, which helps reduce harmful compensatory patterns. Looking at muscle thickness after 4 weeks, the BFR plus core stabilization group consistently outperformed the non-BFR core-only group. For the transversus abdominis at rest, the BFR group increased from 2.42 to 3.17 millimeters. That's a significant 0.75 millimeter gain. Now, we must remember that we're talking about muscle thickness here, and these muscles, they aren't big, they're small. Therefore, these gains are going to be in the millimeters. For the non-BFR core group, the transversus abdominis gained only 0.27 millimeters. During contraction, again, the BFR group was far better than the non-BFR core-only group. For the Multifidus at rest, the BFR group increased from 22.74 to 29.60 millimeters. That's a massive 6.87 millimeter gain. The non-BFR core group improved just 2.29. During contraction, the BFR group saw a significant increase and improved approximately 7 millimeters, while the non-BFR core-only group had only a slight increase of just a touch over 2 millimeters, which was not statistically significant. Finally, for the Gluteus Maximus at rest, the BFR group increased from 21.18 to 29.12 millimeters. Again, another large 7.93 millimeter gain, whereas the non-BFR core-only group improved only 2 millimeters. And during contraction, once again, the BFR group far outperformed the non-BFR group by, it was almost 8 millimeters there. So quite a significant result for all three muscle groups, both at rest and during contraction as well. Finally, looking at the modified Austrian disability questionnaire, this is where higher scores indicate greater disability. The BFR plus core stabilization group started with a mean score of 25.17 and decreased to 12.68 after 4 weeks. That's a reduction of 12.5 points, and it was statistically significant. Remember, lower scores mean less disability, so this is a clinically meaningful improvement. The non-BFR core stabilization only group started at 25.06 and decreased to 20.78, a reduction of 4.3 points, which was not statistically significant. The between group difference was 8.11 points, favoring the BFR group, and this difference was also statistically significant. In the clinic, this means the BFR group experienced a greater reduction in how much their low back pain interfered with daily activities like lifting, sitting, standing, and sleeping. So what does this all mean for practice? Let me start with the most obvious takeaway. Adding BFR to a core stabilization program produces significantly greater improvements in muscle activation, muscle thickness, and disability compared to core stabilization alone. And it does so in just 4 weeks. That's a short intervention window, and the effect sizes are clinically meaningful. For the transversus abdominis, we saw a gain of 0.75 millimeters in resting thickness in the BFR group compared to only 0.27 millimeters in the core stabilization only group. For the Multifidus, the BFR group gained 6.87 millimeters at rest compared to 2.29 millimeters in the non-BFR group. And for the Gluteus Maximus, BFR group gained 7.93 millimeters compared to only 2.22 millimeters. These are substantial differences, especially when you consider that the exercises themselves were identical, and the only difference was the presence of the BFR cuff on the thighs. Trying to understand why, we need to understand the mechanism, and this is where it gets interesting. The cuffs were applied to the legs, not the trunk. So how do we explain adaptations in all these 3 muscles? The researchers propose that the BFR creates systemic and hormonal responses that extend beyond the occluded limb. When you restrict venous return and create local hypoxia in the legs, you accumulate metabolites like lactate, hydrogen ions, and inorganic phosphate. Simply put, these metabolites send a signal to your brain that triggers your body to release muscle-building hormones, like growth hormone. These hormones have systemic effects, meaning they can promote muscle protein synthesis in tissues far from the site of restriction. Additionally, the hypoxic or low oxygen environment may upregulate hypoxia-inducible factor 1 alpha, which enhances angiogenesis and mitochondrial biogenesis, meaning it builds new blood vessels and helps improve cellular energy factories within the body. There's also evidence that BFR increases the expression of mTOR signaling pathways, which, as I mentioned earlier, we just think of this as the body's master switch for muscle hypertrophy or overall muscle growth. There's also a neural component. The core stabilization exercises require the transversus abdominis, Multifidus, and Gluteus Maximus to co-activate and stabilize the spine and pelvis. When you add BFR to the legs, you increase the metabolic demand and create a greater challenge to the central nervous system to maintain force production. This may lead to preferential recruitment of high threshold motor units in the trunk and hip muscles, even though the external load remains low. In other words, the BFR is not just creating a systemic hormonal response, it's also driving neural adaptations that improve motor unit recruitment and muscle activation. Discussing the exercise program briefly, the researchers used a progressive program over 4 weeks, with 3 levels of increasing difficulty. Each exercise involved a 10-second hold, 3 sets, and 60 seconds of rest between sets. That's a time under tension approach, which makes sense for BFR because you want to maximize metabolic stress. As I said, I couldn't find any information about if they release the cuff pressure during the rest periods, but potentially if during the rest period they allowed for a release of inflation pressure, this partial reperfusion, which allows the removal of metabolites, could help to maintain exercise quality while still accumulating enough metabolic stress per set to drive adaptation. And if you're implementing this in practice, I'd suggest sticking to that structure: isometric or slow concentric eccentric movements, 10-second holds or really slow tempos, and a 60-second rest interval. And if you're new to BFR, by decreasing the pressure in between the sets, it's mean that you're going to be able to cope with the BFR pressure throughout the whole exercise program. One thing to consider is the short interval duration. 4 weeks in this case was enough to see meaningful changes in muscle activation and thickness, but we don't know whether these adaptations are maintained long-term or whether they continue to improve with extended training. Previous studies have shown that BFR adaptations plateau after 6 to 8 weeks, so I'd suggest either looking at further progressions of the core stability program or looking to transition to higher load training once the tissue is robust enough to tolerate it. BFR is a bridge, not a destination. The goal is to rebuild the tissue to the point where it can handle traditional loading, then progress accordingly. As always, though, you can continue to use BFR really successfully across the whole spectrum ongoing after this acute phase. A lot of people would do the short acute BFR program and then stop using the BFR. With something like this, you're going to have to continue doing some form of an exercise program ongoing. Think about it as like your own personal health insurance. You have it there, you keep doing it just in case it comes back again. If you stop it altogether, there's a good chance that you may regress. So ensure that you keep progressing your program and you continue your program as well. In closing, let me give you 3 takeaways for today. Firstly, adding BFR to a core stabilization program produces significantly greater improvements in muscle activation, muscle thickness, and disability compared to core stabilization alone in individuals with non-specific chronic low back pain. The BFR group saw a 27% point increase in transversus abdominis activation, a 25% increase in multifidus activation, and a 32% point increase in gluteus maximus activation, all statistically significant and all clinically meaningful. If you're working with chronic low back pain and struggling to drive meaningful strength and hypertrophy adaptations with traditional low-load core stabilization, BFR is a very viable and evidence-based option. Second, the BFR prescription used in this program was applied bilaterally to the thighs during a progressive core stabilization program, 3 times a week for 4 weeks. That's a practical, replicable protocol that you can implement in clinical practice. Make sure you individualize the occlusion pressure, taking into consideration the individual's limb circumference, cuff width, and their response. Thirdly, the adaptation seen in this study extends beyond the restricted limb. This suggests that BFR creates systemic metabolic and hormonal responses that promote muscle protein synthesis and motor unit recruitment in non-restricted muscles. This has huge implications for rehabilitation because it means that we can use BFR to drive adaptations in muscles that are difficult or painful to load directly, such as multifidus and transversus abdominis in people with chronic low back pain. Before I sign off, I want you to think about one last thing. If you're currently using core stabilization exercises in your practice, are you seeing genuine gains? Or are you primarily seeing improvements in motor control and pain? And if you're not seeing the tissue level adaptations you want, what's stopping you from adding BFR to your protocol? And that's all for this episode. If you have any questions related to this, you can get in touch with me through my website, thebfr.co, or socials at thebfr.co. You can also purchase your own BFR cuffs from our website, which is again at www.thebfr.co. And lastly, before I go, a couple of favors from me to you. If you know of someone who would benefit from this episode, please share it. And if you are enjoying the podcast, please give it a rating on iTunes. Thanks for listening, and remember to keep the pump.